Thank you to the organizers for kindly inviting us here. It's an opportunity to give this talk on the clinical aspects of tremor. I would wish to stand right beside the podium because I'm vertically challenged. Even this beautiful setup here is taller than me, probably. So, okay. These are the disclosures. And at the end of this talk, we hope to be able to give you a strategy to correctly recognize and classify tremor, hopefully practical strategy, and explain the approach for assessing tremor, outline an appropriate workup, and explain the possible treatment options. I do have only 2 slides for that, Dr. Singer, and Dr. Singer will kindly, of course, elaborate in his lecture. So tremor by definition is rhythmical. Dr. Helmick said that the rhythmicity is the key here. The other important keywords here are involuntary oscillation, alternating or synchronous contraction of body parts, and reciprocally innervated muscles. So there is no diagnostic standard that can distinguish among common types of tremors, unfortunately, which can make the evaluation challenging. So, however, establishing the underlying cause of this tremor is very important. And this brings us to why it is very important for us to go through history and clinical examination. So in the history, these are the most important aspects. We want to make sure that we know when exactly the tremors came in. So is it of an acute onset, probably vascular, probably psychogenic, or functional, I should say? What is the age of this patient? Precipitating and relieving factors are very important. And topography of tremors. The tremors can occur in any body part, from the head down to the leg, in between the body parts as well. So you have the palatal tremor, you have the chin tremors, you do have tremors in the neck, which can be part of probably dystonic tremor. You have tremors of the hands, sometimes even of the abdomen. So activation of tremors, which makes the tremors, which brings on that or simulates these tremors. Frequency of tremor, how fine or how coarse these tremors are. Family history is very important, both for heredodegenerative tremors or even for those which are not genetic. So how it interferes with daily activities. Oftentimes, the patients come to our clinics because these tremors interfere or makes it socially embarrassing for them to get out. So associated symptoms, make sure to get into other neurologic diseases, drug use, let them list down all the medications that they have used or are using at this particular time, metabolic disorders, thyroid, diabetes, alcohol sensitivity. 70 to 80% of essential tremors do respond to alcohol. There is this newly out review by Lenka and Dr. Lewis on premotor signs and symptoms of essential tremor. And we have to ask from the clinics, what other symptoms that came on before the motor symptoms came out? So even the sleep habits may have probably changed, even cognitive probably have to be discussed. So examination of the tremors would look at the frequency, the amplitude, and of course the location and the modifying factors. So special tests, make sure to try to mimic activities of daily living. So ask them to write. Nowadays, you know that the computers are there, so maybe ask them to hold the mouse or attempt to do it. Do spirals and ability to transfer water between 2 cups. Do this in the clinics. So in this video, may I show you this gentleman who actually doesn't show a lot of tremors if we take a look at him just sitting there. So he does have, so on putting the arms on the lap, there's not much of tremors there. So in different parts of the world, you actually see how they do it. So Dr. Helmick earlier has the hands on top of the arm of the chair. In some parts of the world, you put it on your lap. So, but then, when you ask this patient to put up the arm, there's tremor there. Okay, there's not much of the decrement on finger tapping. This guy has essential tremor. Also on foot tapping. Although you see there's some arrest, some signs of arrest on the leg, of the left leg. Okay. But then, the challenge here is asking the patient to do some of his activities, daily activities. This young gentleman, he's less than 50 years old. Okay. So this is not an attempt to show you that the clinician doesn't have tremors, but that this patient has some difficulty doing spirals. Okay. And do that on the left as well. Okay, so this is a simple test in the clinic, and alongside this, make sure to ask them to transfer water from between 2 cups. The video that was shown earlier, the patient wasn't able to do it, but here you can see that there's this tremors coming out when he transferred the water from between 2 cups. And there's more tremor seen, a little bit more tremor seen over the left than the right side. When you ask him to take the cup to drink, notice, so the instruction was for him to put the cup near his mouth. If you notice, he moved his, so that's a compensatory mechanism on part of the patient. It has gotten used to it, obviously. Okay, so these patients, after the first history, first time that you've seen them, make sure to plan for follow-up. A lot of movement disorders, in this particular case, tremors, sometimes they do present in the first part, months earlier, and then later they would have other symptoms coming out. Or, of course, we expect for progression if there's hereditary illness. So may I present to you this sort of an algorithm for the diagnosis of tremor. Patient comes to you with tremor. Is the tremor physiologic? Physiologic tremor is an inevitable consequence of muscle contraction. And although it is roughly in the order of larger magnitude of these natural contractions. So when this happens, if it is an enhanced physiologic tremor, you have to evaluate for anxiety, for caffeine use, for serum glucose level, liver function testing, thyroid stimulating hormones. And if not, make sure to ask for medications, as we have said. Is it drug-induced? Take him off the medications and see and observe if the tremors actually improved. Is it relieved with destruction? Is it some sort of a functional tremor? Or it has organic cause? If it has organic cause, then move on to the second algorithm. If the patient is young, do have low threshold for doing serum ceruloplasmin and urinary copper secretion. If it is positive, then Wilson's can be treated. So negative, neurologic signs of the symptoms, look into various metabolic and anatomic and genetic problems. And make sure to look for the other signs of being essential tremor. So if the patient is not very young, is it the rest tremor or is it an action tremor? If it is rest tremor, then look for signs of Parkinsonism, rigidity, postural instability, and do treat for or challenge with dopaminergic medications. And if it is not, then maybe ask for a follow-up and watch out for Parkinsonism. So if it is an action tremor, history of alcoholism, withdrawal, or alcohol tremor. And if it's not, then postural or intention tremor, and then treat accordingly. So, okay, so these are the medications that may exacerbate tremor. I'm sure you're familiar with most of them. They can come in many forms. The cardiac medications, you do have a lot of neurologic medications that can indeed induce tremors. So the tremors can be classified according to whether it is fine or coarse. Is it primary or are there secondary causes of tremors? Topographical distribution, is it a rest tremor or is it an action tremor? Under action tremor, make sure to try to distinguish between postural, is it kinetic tremor or an intention tremor or an isometric or a task-specific tremor. So the action tremor occurs with voluntary contraction of muscle, and the postural tremor occurs when the body part is voluntarily maintained against gravity. Kinetic tremors occur with any form of voluntary movement. An intention tremor is a subtype of that kinetic tremor, which is amplified. On the other hand, rest tremor occurs in a body part that is relaxed and completely supported against gravity, most commonly caused by Parkinsonism, but may also occur in severe essential tremor. So these are the types of tremors and their clinical characteristics. Notice the frequencies of these tremors, from the fine tremor of physiologic tremor up to the coarse tremor of the palatal tremor at 1 to 3 hertz. So again, think anatomic, think network and circuitry. Dr. Helmick elegantly has discussed for us the pathovision, the pathomechanics of the circuitry. As much as we want to try to put the localization in one focal part of anatomy, in this case, we cannot. It just is a circuitry problem. A lot of the common diseases that we deal with on a daily basis is in fact a circuitry problem or a network problem. So some of the common disorders with tremor as a prominent symptom would include essential tremor. This is a kinetic tremor as a predominant clinical feature and is commonly familial. We said 70 to 80% of young onset has a positive family history. And we show here the difficulty with, so bilateral, difficulty on doing the spirals. A lot of challenge there for this patient. Even starting to do it is a concern. So, and oftentimes they have to try to support. So this patient is trying to support his arm on doing the spirals. The same, so doing that on the right side, the left side. So in this case, we say that essential tremor is bilateral, but often there is asymmetry as well to this bilaterality. Okay, so we have here Parkinson's tremors. Okay, the typical pill rolling flexion of the thumb over the digits. So this can, so we know that we have to look for the other signs of Parkinson's or Parkinsonism. The tremors can occur from this mild kind of tremor to this severe tremor. But notice here that even if it is so severe already, there is still that asymmetry. Remember that Parkinson's disease starts out unilaterally. And as they progress into the disease, that asymmetry actually prevails, showing us that in this, for example, in this case, the tremor, though severe, is still confined or seen more over one side than the other. In this video as well, you can see that there is the re-emergence of that tremor. Okay, so one of the tremors that is commonly seen as well is that of the dystonic tremor. Notice here that this patient actually has a posturing of the neck, rotated slightly to the right. So this is the beginning of XDP. This patient has X-linked dystonia Parkinsonism. This was one of his first manifestations. Also, he has already noted that he can decrease that tremor by putting that head or the neck in a certain or a specific position or posture. So moving it further down to the right actually decreases his tremor. So we do see a lot of tremors in dystonic posturing. So that's one of his sensory tricks. Okay, so for functional or psychogenic tremor, it usually is of abrupt onset. There's absence of other neurologic signs. There is a lot of distractibility with this kind of tremor and a lot of inconsistencies. So you have to make sure to look for entrainment, and in the history, look through the employment and other concerns with other allied health professionals, presence of other psychiatric disease, or presence of secondary gain. They usually are not responsive to anti-tremor medications, but you can try giving placebo. They can actually respond to that. Okay, so there are other common disorders with tremors as prominent symptoms, and one of which is Fragile X ataxia, which is seen in adult male carriers with fMRI premutation with excess repeats for Fragile X gene. In these cases, the initial manifestation would be a tremor before it is actually followed by the dystaxia or the ataxia. So late onset progressive cerebellar ataxia and intention tremors. So palatal tremor is as well common. We see this as a rhythmical contraction of the soft palate. In this case, there's an acute or a chronic lesion that is usually seen over the rubra, the red nucleus, the olivary, or that circuitry. So red, olivary, and the dentate nucleus. Okay, so for the Holmes tremor, which is in fact a cerebellar tremor. So this is a combined rest, postural, and action tremor. Notice in this video that there is some irregularity to that. It is sort of is jerky, and in fact has other signs of the cerebellum being involved. And in this case, the finger to nose testing in fact showed some dysmetria, as seen here on the right side. This patient has CP angle mass, which was excised, but unfortunately, in the process, had cerebellar stroke on the right side. Okay, so neuropathic tremor is as well common. We do see a lot of diabetes. We have kidney patients who present with neuropathy, and this is in fact kinetic and postural. So when we encounter this, metabolic workup should be done. We have to think paraneoplastic as well when we encounter neuropathic tremors. So common disorders with tremor as a prominent symptom also includes the SCA. This is a rare autosomal dominant ataxia. Initially, the patients can present with essential tremor-like symptoms or tremor before other signs of ataxia can manifest. It is not only seen in common disorders, but it is also seen in rare disorders associated with tremors. And some of these are listed here: hereditary chin tremors, Kennedy syndrome, the Klinefelter syndrome, and the spasmus mutans. So in assessing tremor severity, we have to go clinical. When all else fails, I'm sure the clinical acumen always prevails. And we have make do with some of the ancillary tests, EMG, for example. In the clinic, make sure to do a spirography, a mimicking of activities of daily living, and we can make use of some of the tremor scales that are available out there. So this is a classification of essential tremor from the Tremor Investigation Group, outlining to us the definite, the inclusions and exclusion criteria for us to make a diagnosis of a definite, probable, or possible essential tremor. So this includes the following investigation to look for the cause outside of the routine tests that we do. Make sure to ask for a thyroid function test. I've always emphasized that we should have a very low threshold for copper studies. Iron tests. A lot of elderly out there would have difficulties with iron absorption. Make sure to ask for vitamin B12 levels or vitamin D level. Investigation for the cause of possible neuropathy. Imaging studies, such as a CT scan or an MRI or a DAT scan. Toxicology studies. Paraneoplastic workup, of course. Brain perfusion SPECT, which can detect or give us an idea as to the difference between a tremor that is Parkinson's disease or the tremor that is from essential tremor. So these are the common features of the tremor syndromes with the diagnostic tests outlined here. For the cerebral tremor, for example, we have to make sure to do a head computed tomography or an MRI, an enhanced physiologic tremor, looking for doing some tests to make sure that we look for the serum glucose level, thyroid stimulating hormone level, the liver function testing, patient history, of course, to evaluate for any anxiety or caffeine use. Essential tremor, there's no specific test for these, but do the routine test include thyroid, TSH, a serum biochemistry profile to rule out other illnesses. Parkinsonian tremor, also no specific test, but can do PET tomography or or the SPECT, or psychogenic tremor, which we need to have do a very careful history. So I have 2 slides on the management. This is a table outlining some of the management or the medications that can be used for specific types of tremor, such as essential tremor, Holmes tremor, dystonic tremors, and the primary orthostatic tremors. And with that, there's as well other surgical management. And I just want to be very sure to mention that there are devices that can be used to help these patients. So with that, these are the conclusions that tremor is a common, or not, if not the most common movement disorder. There are several ways to classify tremors. An algorithm for tremor diagnosis can be used as guide. And common disorders that present as tremors can be distinguished clinically. For us in the Asian countries, it's always a challenge to do all the tests. Besides the fact that these are not readily available, the costs of doing these tests is actually, in fact, a challenge. Ancillary tests are, in fact, used to rule in and rule out the diagnosis. So with this, I thank you for your attention.